much, Monte, for that great introduction. Good afternoon to everyone here.
Good afternoon.
Thank you for inviting me to give this seminar today. Wanted to talk about biomedical engineering in a perspective of the sub-Saharan Africa, giving Uganda as a case study, because we share quite a lot of similarities. And I wanted to talk about the current status, what we are really having in biomedical engineering, challenges and opportunities. And this comes as a result of global health wanting to expand beyond the traditional medicine partnerships. So we feel technology has a great deal to play in seeing the advance of medicine. In my talk, I'm going to briefly describe about sub-Saharan Africa. I know that probably quite a number of us here already know. Then talk about what challenges, global health challenges we share, and then look at Uganda healthcare and the burden. Then see how the medical devices and technology can come in to help some of those challenges, the potential for biomedical engineering. And then talk about the trends that have been happening in sort of healthcare technology. And then a brief look into the technologies inspired by the low and middle income countries, as well as capacity building efforts, some of the key points for what that we explored and published in a journal about, in case anyone is interested in establishing collaboration of BME education. Then what exactly we have in biomedical engineering in Uganda, biomedical engineering at Makerere University, as well as where we want to see this go. So we basically have sub-Saharan Africa bearing at least 24% of the globe's disease burden, but we have less than 1% of the global financial resources, very limited human resources, and as we know, it's the world's poorest region, has very high fertility rates, and is predicted to more than double the population by 250. Some of the disease burdens, if you look in the sub-Saharan region, if we look at it, is mainly infectious diseases, neonatal deaths, respiratory infections, and so forth. That's in yellow there. Maybe it doesn't look so yellow there, but it's, that is brown. That brown is the non-communicable diseases. If we are to compare that with high-income countries, it's sort of the reverse. Non-communicable diseases are really the leading cause of death. They cause the most strain on the healthcare provision. But still, there's some infectious diseases in there somewhere. So here we have infectious diseases. And you see there's a difference in the two. If we look at life expectancy within the sub-Saharan region, so this region here, is quite low compared to other places around the world. Some of the scenarios you'll see when you go to sub-Saharan Africa, you'll see slums in the city. Basically, this is a pit latrine, which is usually in a community such as this one, and you can spread infection quite easily. Drainage systems are quite not very well planned, so you can get quite a number of challenges there. And children and communities within these areas fetch water from there. And this is a very common scenario. But also within the rural areas of sub-Saharan Africa, you still get quite a number of challenges. You can get clusters of communities, but also there's quite long distances to healthcare facilities to basically get amenities to use for your necessities. And the technology used is still quite limited in sort of the output you can get. If we look at Uganda, for example, we have a population which is growing very quickly. At the moment, it stands at 4.3 million. This is from a census done in 2015. In comparison to the United States, it's 323 million. We have a gross national income per capita of 630. in comparison to the United States of 56, almost 57,000. Life expectancy stands at 60 for male and 64 for female. United States is 76 for male and 81 for female. And then the total expenditure on healthcare in percentage is 7.2 in Uganda and 17.1. WHO recommends at least 15% expenditure on health, so we are still lagging behind there. We also have a 1 to 20, almost 25,000 doctor to patient ratio, whereas WHO recommends 1 to 1,000. And the nurses are half of that, but still quite a big strain. Long distances to the nearest health center, and the nearest health center will not have the appropriate resources for you to actually get the care you need. Either the human resource will be insufficient, or the actual tools, consumables to use will be missing. Also, we have 5.8 to fertility rate per female. Also, I wanted to point out that the National Referral Hospital delivers over 30,000 babies per year, given all the resource limitations I've given. This in comparison to one of the busiest hospitals, I was told it's the busiest hospital in Europe, Liverpool Women's Hospital, delivers about 2,000 mothers a year, even with all the excellent facilities and resources they have. And the National Referral Hospital gets complicated cases, the cases that could not be handled elsewhere. So this is quite a high number for these people to handle. However, it's not all glim. We still are improving. If I look at life expectancy, so for female globally it's high, but also we are improving. And this was a nice trend that I picked up on, because you can see there was a dip here. We probably were supposed to just raise here. And around this time, there was quite a number of people dying from the HIV epidemic. So there's that dip there. But overall, we are improving, starting from some time in the 1990s. We don't want to just focus on what sub-Saharan region have, but also want to see what health burdens do we share with the high-income countries. We have air and environmental pollution, probably more present in high-income countries than it is in the sub-Saharan region because of the industrialization and so forth. We have antimicrobial resistance. This is come out of so many practices, such as people self-prescribing medicines in low-resource countries, but also this can have repercussions for people in high-income countries. Epidemics, and then here we say whatever we do in low and middle-income countries will at some point come to affect the high-income countries. And therefore, we need a systematic approach on trying to solve this. And hopefully, the partnerships we build will try to look at the whole systems and see how best to come in. The collective global burdens of communicable and non-communicable diseases are a threat on social and economic benefits to everyone involved, not just people in Africa or Uganda. And my case is medical equipment have a great potential to really improve systems in global health. How useful are technologies for sub-Saharan Africa or for low and middle-income countries useful for high-income countries? If we look at it, this is now still summarizing what I was saying, that what we do in low and middle-income countries will have repercussions for high-income countries. Antimicrobial resistance, for example, if you look at infectious diseases. In USA, the focus at the moment might be on MRSA, and in Uganda it's TB, but still these are infectious diseases. Epidemics such as Ebola, Marburg, cholera, and so forth have no boundaries. I think at some point we are just lucky that they don't cross over to so many regions of the world. But we need to we need to know that they have no boundaries. So resource planning and allocations is important. Look at really cost-effective ways, innovative ideas of trying to see how we can bring in this decentralization of healthcare. So point of care diagnostics, for example. In sub-Saharan Africa is the absence of highly skilled health workers or enough skilled health workers. In USA, it's the aging population. So we want to bring the healthcare provision closer to people who are using. The aging population, older people might not find it easy to access the health care services because they need to move to hospitals all the time. So the rationale for medical devices, we know that they have revolutionized healthcare provision around the world. Many procedures in diagnostic, therapeutic, and disease management require a number of medical devices to help you track this. And a number of hospitals in high income countries have invested heavily in the cutting edge technology to tackle some of these challenges. However, most of the low and middle income countries still lag far behind in the utilization of these facilities. Most of the devices you find in sub-Saharan Africa are either donated, inappropriate, or not functioning at all. In a place like Mulago National Referral Hospital that I said delivers 30,000 mothers a year, babies a year, beg your pardon. In addition, we have absence of appropriately trained human resource in biomedical engineering, limiting the application of technology where it is necessary. I'll give you an example of a study we did within Ugandan hospitals. So this is in agreement with so many other studies where, so A is good equipment in use, and you can see that yes, the percentage is a bit high, but there's quite a number of equipment that are really not working well. The area to keep focus on is this region of C in use but needs repair. There's a great number of equipment which are used but really shouldn't be used at all, so we need to really look into it. If we look at the trend of technology in healthcare, at some point it was mainly based on the physician's experience, looking out for symptoms and so forth. And you know, this was signs, symptoms, fevers, and so forth and so forth. This is still highly available in sub-Saharan region. But the challenge is there isn't, you know, enough people to do this. And then some of the diseases are more complicated. Equipment have become sophisticated over the years, and huge need of input by skilled technicians to look after this equipment, and creates many challenges in low and middle income countries because of the lack of skilled people. Decentralization of healthcare. So here is now task shifting. People who are not trained to do, say, diagnosis can do it because the tools they have available allow them for such. Lack of skilled personnel, aging population in high income countries, point of care, rapid diagnostic testing, telemedicine, health, all these, we see it as the sort of the future for healthcare technology. There's been a number of devices that have influenced provision of healthcare, but I put there banking because this has revolutionized Africa, the way people do banking in Africa. And we hope that we can borrow a leaf from that and be able to put this into healthcare technologies. These days, even my grandmother in a village deep there can get money sent to them quite simply by me just sending, putting in a simple codes. So, and she doesn't need to really know highly sophisticated technology or use of smartphones. But there's been a number. So these machines have been designed, this one and this one, they are anesthesia machines. They've been designed by companies. This one mainly designed in the US, this one in the UK. They work with or without oxygen, with or without power, and they really are very basic to run. They're very robust, and they run for so many cycles before breaking down. Then rapid diagnostic testing. These days, people can test for malaria, HIV, within any part of Uganda. And this one, harvesting some of the resources we have, is a prosthetic hand that gets energy from the sun to be able to keep active. So basically, if you've got it on you, you can keep recharging and it will be active for many hours. And people have started investing in 3D printing. Some of this has been successful because we are starting to embrace the BME contribution to healthcare. And we do this through a number of development partners, such as the Japanese International Cooperation Agency, very present in Uganda, SUSTAIN, which is a USAID-funded program, PEPFAR, which is also USAID. There's Medical Aid International. Of course, this is not an extensive list, but the development partners are working to see that this improves the healthcare provision within hospitals. And the focus is mainly within hospitals. And many countries in sub-Saharan Africa have now developed training programs at diploma, degree, and master's level through collaborations with a number of institutions, mainly in the United States. And I wanted to give some of the examples of these collaborations. We have one at Rice, and at Rice, the key aspects started by Profs. Rebecca Richards-Cartom and Maria Oden, the 360 Institute for Global Health. And in there, they have a goal to improve healthcare through innovation by building and sustaining an international cadre of innovation leaders, and train engineers to build practical new technological challenges, infusing engineering skills with entrepreneurial thinking and working across geographical regions and multidisciplinary approach. And so under their program, the undergraduates work on design problems identified by partners, mainly in Malawi and in Brazil. Some of their outputs and outcomes. So they have internship programs, student internship programs there, and also exchange programs for faculty. They've developed technologies such as devices, syringe pumps, device for PPH, and hand-powered centrifuges, electronic medical records. They've also helped Malawi to come up with a biomedical engineering program. And they've shared this at the TEDx talk in global health for their efforts in Malawi. University of Michigan. This has been headed by Professor Kathleen Sienko, and provides engineering and non-engineering students with credit-bearing and internship opportunities centered on global health, needs assessment, and co-creative context appropriate design experiences in international and domestic field sites. Prior to the entering of clinical immersion sites, students learn the tools of design ethnography that they will employ to identify, define unmet needs, and characterize use contexts. And they've been working with Ghana and have performed needs assessment during clinical immersion experience. And upon returning, the students generate concepts and fabricate and evaluate the prototypes. Some of their outputs include portable pelvic examination tables, subdermal contraceptive insertion device, and they've generated a number of abstracts and conferences. But they've also commercialized devices such as the Hemafuse. And they've also given this on TEDx talk. Looking at Northwestern University, we have Prof. Matthew Glaxberg, working with Professor Tanya Douglas in University of Cape Town and some Nigerian University of Lagos and University of Ibadan. And they work also to emphasize the user-centered design and development, supported by expertise from Faculty of Medicine and Business. Group is also developing a BME textbook for the African context. And visits by Nigerian faculty to University of Cape Town for up to 10 weeks to learn and appreciate the design. Some of their outputs, they've worked together to win a Fogata International Center training grant. They have staff exchanges. They have faculty members participating in universities from engineering, business, and medicine to have locally grown healthcare solutions in Nigeria, and also interinstitutional projects. So they've worked on projects such as the infant surgical warmers, burn injuries, and blood management system. They've also developed a journal called Global Health Innovation to disseminate some of these great findings with their collaborations. Case Western University. We have Case Western University is actually with Makerere, working in partnership with Makerere University. They've been in Uganda since 1988, since they were invited by the government to intervene in research for HIV epidemic. And so their research is mainly on HIV and AIDS. And in 2011, Makerere School of Biomedical Sciences admitted the first cohort of undergraduates. And so Professor Andrew Rollins and Janet McGrath, who's an anthropologist, saw this as an opportunity to develop an interdisciplinary solution to global health issues. And so they offered a class at Case Western Reserve University, and the students worked together with students at Makerere University to develop solutions for challenges. And they work also with a local district which has got small health centers, community-based health centers to look for challenges and also come up with solutions in relation to that. Some of the outputs, project focused on 3 areas: cold chain vaccine, vaccine cold chain, I beg your pardon, medical waste management, pediatric pulse oximetry. And this has been feeding through. So students are recruited and they work on those projects, and when they go, the projects stay behind and recruit more students. Integration of teams from Makerere and Case Western. And a new module at Case Western was developed where the students actually do study from that. Then, close at home, Duke University, we have Professor William Reichert, who's here with us. He spent a year with us in 2014-2015 academic year, and helped with a number of things, including teaching and also a thorough curriculum review, which helped us to address some of the challenges that we are having with teaching the program. So there's a 4-pronged approach for Duke, teaching BME classes taken simultaneously at Duke and Makerere students. So here, even with him having come back to Duke, students have carried on taking classes in biomaterials, for example, that are taught at Duke with the support of video conferencing and recording devices. And also BME students work collaboratively on global health design issues, and also bringing on board the Engineering World Health Institute to bring students to Uganda for experiencing our challenges. Thomas here was among the first cohort that came. Offering full scholarships to BME graduates who can come back to our faculty and teach. Some of the outputs we have, this is the scholarship for students. Some of the projects we've been working on, pre-eclampsia rapid diagnostic kit oxygen splitters for distributing of oxygen in pediatrics, heat moisture exchangers to tackle the infection control, incinerator filters to tackle environmental damage issues, automatic control suction machines, slide dryers for use in labs, phototherapy blankets. Also, we facilitated a video conferencing facility which helps us to run modules with support for our teams. And also a new module taught by Professor Reichert has been developed here, and the class takes this, and they visit us in March, and we discuss the ideas. But also we are moving beyond just teaching bachelor's, undergraduate, and we have co-applied to an NIH training grant, which I'll talk about later. And the Engineering World Health Summer Institute in Uganda is growing. We are having 12 students coming in summer. This year, we started with 8. Some of the students who have come from Makerere to Duke, we have had Kenneth and Henry, and they were here till, and they finished their degree, master's degree in December. So we are grateful to all the members who have been participating in that. And we have a new team of students, Beryl and Emmanuel. They are right here, sitting amongst you. So really glad, and they are really keen to be involved in this. So they have a payback time. They come back to Makerere and they will be tasked to teach at least for 3 semesters, and they can explore other things. And also we'll be having, well, the next 2 starting in January 2018 are here, but I've just talked about them. We looked at key things for a good BME education collaboration in our low and middle income countries. You need to consider whether to be deeply immersed in the collaboration or to support on the peripherals. And some of the key things I outlined, I'll summarize some of them. Make available existing course materials, because in the United States it's easy to find resources to develop course materials. In sub-Saharan Africa it's not as easy. Use distance learning technology. Our conference facilities use Skype. They don't really use complicated software also to really exchange. Offer existing or new online courses to help to run these programs. What I didn't say is this was published in a journal that we co-authored with a team from a number of partnerships that I've mentioned earlier. So it's published in the Annals of Biomedical Engineering. They're called Sub-Saharan Education Partnerships. So you can find out a lot more. And we find that it's useful to start an EWH chapter, because then it encourages close interaction with the students as well. Bring BME students from partner institutions if possible. And one of the windows we identified is the research experience for undergraduates, which is available to many US institutions. And bring building visits for one student to partner institutions. And we are saying if you cannot do it right away, you can engage with the EWH team who can facilitate that to some extent. Work in partner with partner institution teaching staff to develop or refine the curriculum. We definitely need that input. And also establish a design program that takes co-originated ideas from concepts to prototypes. So this is quite important. And for the BSc programs, we find that they all have design components in them, and they are the easiest entry route for collaborations. We can start working on design prototypes together, as it has been identified on the previous slides. Use educational partnerships to build research collaborations that address problems significant to the partner institutions. So we want to move away from simply supporting bachelor's programs, undergraduate programs, to building research so that we can move things forward in terms of addressing the challenges. I want to focus in a bit on biomedical engineering in Uganda. At the moment, there's 4 institutions: Makerere University, Mbara University, Anesco Ultrasound Research and Educational Institute, Chambogo University, all offering bachelor's degree. The bachelor's degree was started in 2011 by Makerere University, and now others have jumped on board. So the Chambogo and Mbara started last year. Ekuri started the year before. So others are catching up with Makerere. 3 institutions teaching diplomas, so Chambogo, Ekuri, and there's Uganda University. Where do the students go? There's so many privately owned companies. One almost springs up every day. Yeah? And also we have internationally represented companies. So these students will go and work in there. The people employed in public hospitals are mainly funded by donors and non-government organizations. So a number of these people have not been taken in as cadres. However, there is hope. We've been credited for actually creating the quickest acceptance of the cadre of biomedical engineering within the Ministry of Health structures. So regional referral hospitals have started recruiting these graduates of biomedical engineering. Mulago National Referral Hospital has actually embraced the fact that they need a department of biomedical engineering. And so far they've recruited 1 biomedical engineer, 1 of our graduates, and 4 technicians. So these are going to start that going. So it's really promising in Uganda. I think we are moving quicker than probably most other parts. Focusing in on Makerere. Makerere is one of the oldest and probably most prestigious universities in Africa. Started in 1922 as a technical school teaching carpentry, building, and mechanics. And that was the need of them. And what I say when I get to 1922 is we are 2 years older than Duke University. So, in 2011, we formed a college system, and so we have 10 colleges operating as semi-autonomous units. So in the College of Medicine, where biomedical engineering is hosted, there are 9 schools. These schools, we are in the School of Biomedical Sciences and under the Department of Physiology, because physiology has more equipment, and so that's where we are hosted. For biomedical engineering at Makerere, one of the first BSc program in sub-Saharan Africa out of Egypt and South Africa. I was told that Ghana started before us, but this was quite recent. 2011 we started. We have a vision of creating a cadre of looking at current bioinstrumentation challenges. And by that I mean fixing equipment that are broken. But also we will have a vision of developing locally innovative medical technologies. We started with 19 students. One of them is Emmanuel here. And so far we've graduated 3 cohorts. Berili was in the 2nd cohort of students. We currently have over 120 across the 4 years. It's a 4-year program. And we train students to look at the current problems, but keep an eye on where the future is going in healthcare provision. What are we missing at Makerere University? We are missing properly trained and sufficiently large teaching faculty, adequate instructional facilities, reliable internet. When we come to the US, internet is everywhere, but in Uganda it's really a luxury for some places, but also power. Power is not always there. We have had to run lectures with Professor Reichert here without power, and we just have to recite from our laptops and writing on the chalk. Opportunities for fertility with. So we want to look at ways of acquiring funding, participate in technical writing, education and internships at institutions where people, our students and faculty can see how things are done in first world countries, hands-on method experiences, identification and development of technologically based solutions. Some of these examples, this is repeating, but I wanted to focus on here a little bit. We have had examples of successful, relatively successful projects. And I can focus on one. One of our students went to a hospital, Makerere Regional Referral Hospital, and we found this problem. It's not very clear here to see, but the problem was the suction machines they were using in these hospitals had the valves, the non-return valves missing, and they would suck in the blood and fluids within the electronic system. Of course, for infection control, this is alarming, but also for the device, it stops the machine from working. So already we are restrained on resources of the equipment, but even the equipment we have are breaking down because of maybe incorrect use due to a number of reasons. So one of the students from Makerere came, identified this problem, and developed an automatic switch-off suction device. This went on to win actually quite a number of awards. But the bottle basically had engraved within it an alarm system, but also an automatic switch-off once it's completely full. It has worked well, but some of the challenges that we haven't mentioned is it got to a point where we can't take it any further. Quite a number of hospitals are very interested in this device, but it's still sitting somewhere in our BME workshop, waiting for inputs for it to go to the next stage. That's an example of so many others, such as, since we started in 2011, our innovations have been winning awards. They are not, glamorous awards, but they are worth mentioning. UNECA is United Nations Economic Commission for Africa. Our students won awards in social impact, highest economic impact. 2012, we won, again, CAMTech is Consortium for Affordable Medical Technologies. This is from Massachusetts General Hospital as in collaboration with Imbara Hospital. Then also UNECA still. Then the suction machine won 10,000 awards, $10,000. And you see, every year we've been winning something. So to show that even with our students, things have been really moving very well. Makerere University started what they call MacVaste Award, which is the most innovative technology-based device across the entire university. Doesn't matter which school or college you come from. And we are the first ones to win it. Our students won it. So it's really giving us a lot of excitement and potential. And 2016, we won first, second, third, and fourth prizes in that. And by we, I'm actually speaking for the students. These students have been really inspirational. And other people are coming in, like the UNSFPA supported one of our innovation based on an app developed by one of our students for predicting the risk of fistula, which is a very common problem in Uganda. 2017, still winning, the pre-eclampsia stick, pre-eclamp stick. And what this I mentioned, Denali Dow. So our projects, we are working collaboratively. Denali, she was here at the Duke Global Health Institute. She's worked very diligently with our team of students, and they've developed a device which is really taking over the world by storm. And this device, to detect early preeclampsia, has been winning awards, including the Big Ideas Award, and also it's won a number of other awards. And there's a company here within the United States very keen on taking that device on so that they can manufacture it commercially. Also with Case Western, we've won money for funding. But as I mentioned earlier, we are looking to moving away from just supporting undergraduate and looking at how can we build research capacity. So I've been involved with the UK mainly, this is Engineering and Physical Science Research Council, teaming up with the Department for International Development and they invited calls to see how can we address global health challenges. So 1.4 million is shared with a number of universities in the UK, and Makerere, the co-investigator, and we are sharing 1.4 million. Not saying this to brag, I'm saying this to show that it is possible, because there's a number of things that we can really look at to move things forward. This is really to develop a prosthetic hand for people who have been amputated. This came out of a lady whose hands were amputated because the husband was fighting over money, which was less than maybe $20, and the hands were chopped off. We took an interest in it, and we've been investigating, and over time we've now got money for it. Also with Glasgow University in the UK, we've got money, still the same funding vessel to work on diagnostics for malaria and bilharzia. Then we have two Grand Challenges seeding awards, each worth $100,000. The reel is on one of the teams, but at the moment we haven't signed the contracts. They're still doing the due diligence, so I won't really go so much into the details. But this is still showing us really excitement that the future is very bright. We are doing this with our collaborations. I won't go so much into this because I've already given this, but our key people here is Professor Monte-Reichert and also Professor Bob Malkin supporting us. So all this I've explained about. And Case Western Reserve has been really key at supporting us as well. We have other collaborators. John Hopkins, we have Fulbright Professor Samson Jasso, who's visiting. University of Georgia, William Sarita, originally from Uganda, but working in the University of Georgia, works with us. Queen Mary in University of London, where I studied, Professor Julia, she's been given a few lectures. Engineering World Health has helped to bring a new dimension of helping to solve the bioinstrumentation issues. We also have the Rotary Club of Westminster in Canada, Vancouver. And here they give placements to two of the best performing students to go and experience life in developed country. And Emmanuel here was one of the students who got that award to go. We also work with the African Biomedical Engineering Consortium. This is a consortium of African universities, whether they have BME or not, but interested in seeing technology innovated and utilized within Africa. You don't necessarily have to be an African university. Anyone who is interested can join this consortium. And among this, we've won a number of awards, such as the African Biomedical Engineering Mobility Award, where people, staff, and students go and visit other universities, either to study for masters or to see how other things are experienced. Some of the key challenges to solve: we need calibration, is completely missed in almost every place. Equipment have sufficient budget for research facilities, and this is because there's money from grants, but not in healthcare facilities. We fly in technicians to repair something. Even an air ticket is probably enough to pay for one technician for maybe 2 or 3 years if they are within Uganda. Regulations and policies are not properly implemented. Routine user training is missed, and this is usually important for keeping the equipment running. We have most of the equipment designed from abroad. This might not be a challenge, but maybe some of the local factors are not taken into account. Therefore, what are the opportunities that we could look at in BME in low and middle income? So we could look into, all this is probably into consultancy, systems for repair and maintenance, health technology management consultancy into the entire medical cycle from design. We have our suction machines sitting, waiting to be moved on. We could get some consultancy in that. Capacity building and strengthening efforts. Contribution to standards, guidelines, policies. Key to this is the implementation of them. They are very nicely written in books somewhere. Contribution to developing of appropriate innovative solutions. And also innovations such as design partnerships. We need to undertake research from determining the baseline data for a number of things. Professor Reichert has worked to establish what the baseline is for biomaterials within Uganda, and we've published. It means that people coming after him will read what is published with the students, and they will take it from there. Being involved in clinical and device trials, validation of devices, post-market surveillance. This is quite big in the United States and Europe, where a device comes out in use and people follow it up. It's completely missing in our settings. We could also look at remote data analysis, just so we can maybe outsource some of the things that could be done in our settings. Where do we start from? This is given as a slide of some of the areas that biomedical engineering can look at basically. And we are saying, well, we can't start from looking at everything. And at Makerere, we are saying, well, we can leverage some of the existing world-renowned expertise. In diagnostics, we have good microbiologists, molecular biologists in TB, especially research. Rehabilitation and assistive technology. Big data analytics, we have strong teams in epidemiology, so we can really put our efforts in that. Medical imaging, looking maybe at processing of images. We can do this remotely, sort of helping the teams in developed countries to work on this. Some of the tools we can use, relatively low-cost tools are already existing within our Makerere systems. Instrumentation, molecular diagnostics, we have a big lab. Nanotechnology, we've been awarded the African Center for Excellence in Nanotechnology and Material Science. We have a team of computer scientists and programmers who are really into developing systems on computers and also app development. Our long-term ambitions, we look to build a center of excellence in design, innovation, research, and consultations. We look to establish strong staff-student exchanges, and it's not just a one-off or over 2 years. We have running a D71 planning grant for assessing masters and PhD. We have a good chance to win the D43 grant, which we put in last year. We got a score of 46, but generally, the program officer told us that we stand a very huge chance of getting it, to an extent that she told us to give her to review, to give her to review it well before we submit. So that at least we can help to bring some cadre in training. Seeking to partner to write an NIHU01. It's a biomedical engineering research partnership. One of my reasons for also visiting Duke is to see if I can get some partners to utilize some of the opportunities. But also I'm looking for people to suggest other opportunities. What do we require to make our BME strong? Facilities, access to training material, lab and supports and workshop support, building research capacity. I am very keen on that one. Human resource, staff exchange, capacity building, short-term training, if it is available in the country or people coming over to the United States. And also quite key is mentorship. And mentorship can be done online. You don't have to actually be in Uganda present. Maybe for me, building research and mentorship is the key thing that I want to really see happening right now. Student exchanges. Students come back with excellent ideas. You can provide internships, co-creating ideas and solutions as well. Problem-based learning. So depending on what you want to learn from within Uganda or what our students want to learn from Uganda. What I'm looking for, particularly from Duke, is someone to carry on Monty's, Professor Reichert's work, as he's going to retire very soon. So I'm really wanting to see someone say, well, let's take over the mentor and see that we run this quite successfully. We have some money to host someone, and this money runs out in March. So I'm giving an opportunity for whoever is interested to come visit us and see how we can take it from there. I want to thank you very much for your attention, and I welcome any questions.
Questions?
It was a wonderful talk, and I very much appreciate the systematic way that you guys really pushed a huge monumental task. Let me ask you a couple detailed questions about your training programs. Now you have a few years of experience in your belt. I'm Henry Rice, by the way. I'm a pediatric surgeon. Do you have data on your retention rates of your locally trained BME grads, especially those that have done some international training? Have they remained in Uganda for the most part?
All of them have remained, apart from one. Yeah,
Wow.
the other two are these two. They are coming back.
And let me ask you a second question. In terms of the capacity building across the Ugandan health system, is it common practice for there to be some level of engineering expertise at the district hospital level, or is this what you are training for? Is this mostly at a higher national referral hospital level?
At the moment, it's at the regional referral hospital, but we are really campaigning for it to go down to the small health centers, at least the health center 3.
Is there a need in those environments?
There is a need, maybe not at every health center 3, but maybe one technician to cover 3 health center 3s. That would be really useful. Yes.
So fantastic progress. It is so impressive. Quick question. In terms of interactions with the School of Medicine faculty, how do you get together?
Yes, thank you. So the School of Medicine, basically, they are involved with the teaching of some of the modules. Also, they are involved in grading some of these innovations before we put them out to the world. And what Professor Reichert has suggested in the past is we need to get them thinking of problems as well. Traditionally, how we've trained our students is they go out and speak to any clinician they want to try to think of problems. And we are now trying to work on Professor Reichert's suggestion to see that there's a team of medicine professors and practitioners whom you can always rely upon to bring in some of these challenges and be able to mentor the students through their design progress. Yes.
I think that the important point here is that here at Duke, people in the medical center think of the BME program as an important resource that they can tap into. And that culture hasn't quite made it over there. So one of the things that Robert's trying to do is to try and get that going. I want to say that, Robert's, very humble and so on, but he has really taken this lump of clay and molded it into something really special. And I also want to mention that the first author on the article that he referenced is sitting right here, Brittany Ploss, is one of your products. But anyway, Robert has just been fabulous.
Yes.
Great presentation, Robert. Good to see you again.
Nice to see you.
And so I see opportunity. I'm thinking of the equipment that's actually being used is made manufactured by a specific company. And I think in your talk, I didn't see much of the collaboration between the institution of biomedical engineering and say a GE or another manufacturer. Is that something you're trying to think, and possibly that the downtimes in those equipment, fixing of equipment, could be something that could be leveraged between public-private partnerships?
Yeah, that's a very fantastic suggestion. We have started discussions with different companies. I have personally approached GE, but they had already invested in Kenya. But so it's but then there is also what's the name of the company? Draeger. Yeah. So Draeger are willing to work with us. I think because it's they are private companies, probably profit driven. On top of their list, they want to see what's in it for them. So GE partnering with the Kenya institutions, they're actually doing training and charging quite a lot of money for the training. And actually, it has sort of failed to take off at the moment because we can't afford that training. Yeah. So what we've done with DREGA is, with the renovation at Mulago Hospital, they are equipping the new hospital, the renovated hospital with DREGA equipment. And as such, we've actually managed to work with them to donate equipment to us, and we are trying to set up them as a training center for DREGA equipment, where clinicians and biomed technicians can come. The challenge,
Cheaper than Kenya.
it is cheaper than Kenya. The challenge is that's one provider, and of course we have a number of equipment coming in from all over the world. So, but at least we are looking in the direction of pointing us.
Do they think it's a good innovation hub for their R&D, trying to use the students to think? If the students are brilliant and smart and can help them accelerate the process of the R&D piece, is an innovation hub for them?
To be honest, I haven't had that sort of discussion, but it's an excellent suggestion. I could try to entice them in as well.
It's cheaper for them.
Yeah, it is.
You've got time for one more here. Any other questions? Well, let's thank Robert for a lovely